it's very important in the general medicine and of course in the dentistry as well, because it is reflecting in the dentistry that we have a lot of old patients and old people to treat dentally as well, and some significant percent of the patients we have in adulthood. And we have in adulthood, in aged person, different problems, of course, than in young ages and than in children, of course. And we have a specialty in dentistry. This is the gerodontology, geriatric dentistry, dealing with the old people and the most common problems of the aged old people, dental problems, because the aging process may affect the whole oral cavity, and not just the hard tissues and dental tissues, but the surrounding tissues as well. And in old people, we have general problems, which general problems may cause some local symptoms and local disorders in the oral cavity. So we have to deal with aging as a physiologic process, because sometimes aging can cause pathological changes more frequently occur in older people, aged people, than in young people, and in aged people may have more frequently disorders, diseases, cause problem in the oral cavity. So by definition, the aging is an irreversible, time-dependent process which may occur in all biological system after the system reaches the vitality, the peak of vitality. And the problem is that when you aged, your body will be more sensitive to different diseases, to different disorders. And we can differentiate between primary aging and secondary aging. Primary aging is the normal physiologic aging or senescence in general medical term, and this is the physiologic process. You remain healthy even you are getting older and older. And we have the secondary aging. In secondary aging, we have degenerative processes, degenerative diseases can cause changes inside the oral cavity. So we have changes caused by primary aging and secondary aging as well. Of course, in secondary aging, we may have similar process than primary process, but it is more accelerated. So the local symptoms and local findings could be more accelerated in secondary aging, because in secondary aging your body is weaker, and you may have some problems and some disorders could affect the oral cavity and the tissues of the oral cavity. When you would like to explain the reason of the aging, why we age, you have to find some theories in the literature. You can find some theories. For example, error theory, it means we have complex metabolism in the body, and in the body we have more and more so errors in the metabolic processes when we age, during aging, by aging. And there is the cross-linking theory of the aging. It explains that the aging, changes of the aging could be associated by the cross-linking which are more abundant in older people, and with time these cross-linkings between basic and very important large molecules are increasing the numbers of cross-linking. For example, we have cross-linking between nucleic acids and proteins, and this activity of these molecules is blocked by this cross-linking and by process. Where and tier theory, we have vitality capacity, and this vitality capacity tearing continuously with aging. This is the meaning of this explanation. And we have free radicals, oxygenated molecules, very active and damaging molecules in our body can damage the vitally important large molecules like nucleic acids, and from this damaging with time, this can continue, this can even kill the organism with aging. And immune theory, reduction of the immune capacity and function of the cells, immunoactive cells, is changed, and because of this changing and deprivation, we have more autoimmune disorders, diseases, which can ill the patient and can lead to age and death. Of course, waste product inside the cells, waste products and byproducts of the metabolism metabolical processes accumulating, which can kill cells and the body as well. And genetic theory, we have genetically coded long lifetime in our DNA, and this will determine your life interval lifetime, and it is true in some aspect, because in 40% of the cases we have severe genetic background for the lifetime. So when your parents and grandparents lived for a long time, there is a good chance for you, at least 40%, that you can do as well. And the collagen theory, accumulation of the extracellular matrix molecules can deplete the blood flow and the activity inside the body, and can cause problems, especially with parenchymal organs, for example, the lung. In the lung, when and in the salivary glands, when the collagenated and the proteins are accumulating, that proteins and collagen are accumulating, the function of the cells will decrease. And enamel, so in the dental tissues, we start with the hard tissues and the changes of the enamel. Of course, after eruption, we have pellicle, cuticle, and after pellicle, we have on the surface of the enamel, which is a very thin glycoprotein layer, and we have the parenchyma surface. These are, depressions, transversal depressions on the enamel surface and the tooth surface, and these parenchyma and the wavy surface of the enamel will disappear some time after eruption because of the function, the friction between the food and the surrounding tissues and the enamel. So the enamel surface, from the enamel surface, the perichematous will disappear, and continuously we have attrition, this physiological loss of the enamel tissue, and in the enamel we have microfractures, and the permeability of the enamel is changed with aging, and because of these microfractures, discoloration is seen in the enamel, because some molecules some micromolecules can cause discoloration in the enamel, accumulating into the microfracture sites of the enamel. So in older persons, you can see usually grayish discoloration in the enamel, and as you know, the aesthetic function of the enamel is reduced, so it is less aesthetic. And permeability, as I mentioned you, some say mineralization is changed, but it is hardly true. After the literature, studying of the literature, so no significant changes we have with aging, and the good effect that the caries is inside us, and so the caries sensitivity of the enamel is reduced, so it is less sensitive, the enamel. So you can see the attrition. Because of the attrition, you can see aesthetical and shape changes of the whole tooth. Sometimes you have to repair or the attrition, or place more frequently clones to rehabilitate the aesthetically and functionally the whole tooth and the enamel. And it is a little bit more fragile, brittle, the enamel, because of the water content, the very little water content of the enamel is even reducing the enamel water content, and the permeability is changed, as I mentioned you, and the color changes could be inconvenient, of course, and but positive side that the caries resistance of the enamel, less caries is found in the enamel, but on the other side, that the cementum caries or neck caries, the frequency or possibility is increased in older persons. And ion composition may be changed a little bit. And the other tissue, which is a living tissue and sensitive tissue, and the aesthetic and the function is important either, because the aesthetic is important because the adhesion, the more prominent color of the dentin is visible sometimes, because as you know, the dentin is darker and dark yellowish, the color usually. So again, the older dentin, so the aged dentin is less aesthetic because more inorganic component is depositing, and especially in the peritubular dentin. You know, in the peritubular dentin, this part of the dentin is affected mostly or mainly. As you know, after eruption, some time, 2-3 years after eruption, the apical foramen is formed, and the formation of the apical foramen is finished, and of course we have some, because of this, we have some blood flow changes and metabolism changes in the pulp tissue, and as you know, the pulp peripheral layer is the odontoblastic layer, so the activity of the odontoblasts is reducing with this process with the formation of the apex. You know, when the apex is formed, finished, and it is shrinkaged to the normal size, the periapical foramen, the activity is reduced, and instead of primary dentin, the secondary dentin is producing, you know, with a slower amount, and this secondary dentin continuously reducing or shrinkaging the size of the part, and besides this secondary dentin, which is formed generally, you know, so it is a generalized formation of the dentin, so all over in the periphery of the cavity. So in the radicular part area, in the canal, and in the chamber. In the palm canal, palm chamber is affected by the secondary dentin formation, but sometimes depilative dentin is formed and deposited, but only locally. Depilative dentin is, or tertiary dentin more precisely. But you know, we have two different types of tertiary dentin, this depilative dentin and reactionary dentin. In old people, maybe the reactionary dentin is more important, so I don't think it's depilative dentin. But you know, this tertiary dentin is formed locally, only locally. For example, when you have an aged enamel and adhesion, the adhesion as a mechanical stimulus can react or can cause changes in the dentin, and tertiary dentin is formed locally. And when the process is normal, you will see tertiary dentin, so when the adhesion is normal in rate, so slow progression adhesion, in slow physiologic progression of adhesion, you will see tertiary dentin formation, but sometimes when the adhesion and when the erosion and even caries is very rapid, the changes is caused, is very stressful for the odontoblasts, and they withdraw the processes, and empty spaces leave there, so not filled with, the spaces will not filled with peritubular dentin and tertiary dentin, but so-called dead duct or dead ducts are forming. These dead ducts are dark areas in the dentin where the tubuli are empty because of the withdrawing, you know, so of the processes, of the odontoblastic processes, and with, so it is usually in rapid changes where the odontoblasts are affecting significantly. But normally, so-called sclerotic dentin is forming. Sclerotic dentins means the obliterations of the tubuli, obliterations by the peritubular dentin. This is the sclerotic dentin, or glassy dentin, you know, the sclerotic dentin means like sclerosis in the artery, in the vessels, in the blood vessels, you know, sclerosis. Like in the dentin, you can see almost similar process. And in the predentin, we can see also changes because the predentin layer is thinner in old persons, and odontoblasts are fewer in number because some odontoblasts cannot survive, so cell death cause this numbered reduction of the odontoblasts, and the permeability of the dentin because of the blocking of the channels or the tubuli by sclerotic dentin, the permeability is reducing of the dentin because the tubules are obliterated by peritubular dentin. And the sensitivity is decreased as well, the dentin sensitivity. but it doesn't mean that you can treat that you can drill the tooth without anesthesia, because the patient or the aged people pain suffering and pain sensitivity is increased. So the older people cannot tolerate the pain as good as younger persons. So you have to take care when you do a vitality test, with electrical stimulus or with cold, because you can cause some unnecessary pain to the patient. So you have to do this only gradually. First, small current, small electric stimulus, then you can increase gradually to check the reaction of the person, because the reaction time of an old person is prolonged, longer reaction time. Okay, they don't know what you mean and what you like to investigate, so the reaction time is increased. And so you can see here the changes. Secondary dentin formation. Secondary is physiologic incremental formation, of course, because the dentin is incrementally formed. In hard stimulus, you can see sometimes dents, wide and empty dentinal tubules, mainly because of the erosion caries where the odontoblasts reacting with withdrawal of the processes, so the tubuli become empty, not filled with odontoblastic processes anymore. And the reparative dentin, as I mentioned you, because some problems, caries, erosion, attrition, periodontitis, or even fillings, can cause reparative dentin. They say that when you face fillings, the reparative dentin is more irregular in fillings than any other cases. And you can see in dentin narrower of the tubuli, sclerotic dentin, and mineral content of the dentin is increased. And you can see here tertiary dentin, attrition. Sometimes you can see dead ducts, but these are darker tubuli, and this is the tertiary dentin. The tertiary dentin is very mineral here. So this is the high, the whitish shade. And the pulp changes. Pulp is reducing in size. Even in the root canal, you will find some elements of the pulp. Even the person is older than 80 years, but sometimes the pulp canal is or the root canal is obliterated completely. But some remnants you may find, and it could be very sensitive when you root canal the tooth. Sometimes it is necessary, and the reactivity and defensive capacity of the pulp is reduced with aging, because less cell content you will find in the pulp, and more fiber content, even elastic fibers. The number of or the amount of the elastic fibers is increased, but collagen fibers as well. And less blood supply, and nerves are degenerated, and sclerotic vessels. So and it is caused partly because of the secondary dentin formation obliterating the apex. And the apex obliteration, or the reducement of the diameter of the apical foramen will reduce the vitality of the and blood flow of the pulp, and the sensitivity is decreased of the pulp because the nerve element, peripheral nerve elements will be fewer. And pulp stones, you will find different pulp stones, denticulus, and pulp stones. You can use these terms. You can differentiate between embedded, free, and partly embedded or attached pulp stones, and the pulp stones could be true or false pulp stones, and calcium phosphate and crystals are depositing to the surface even after inflammation. So there is a core of the mineralization from inflammation, from macromolecules, and from after cell death. And this core will be bigger and bigger because of the deposition of the ionic calcium phosphate material into the pulp stone surface. And of course, in true denticulus, we have tubular system because the tube, the denticulus are dentin particles. And especially these periapical area or near the apex of the pulp channel is very sensitive to calcification and stone formation, And you can see the shrinkage of the pulp chamber here. So the pulp volume is reduced with aging, and the shrinkage is asymmetric because it is totally obliterated after 70 some years. It is obliterated. So the blocked the upper and lower deposition of the dentin. So the vertical dimension of the pulp is diminishing, but the periphery is reduced less. So more dentin secondary dentin is forming at the top and bottom of the chamber than at the periphery. So the chamber becomes smaller, but the size changes is asymmetric because the peripheral reducement, axial reducement, peripheral reducement is slower than the vertical. And of course, the pulp horns are obliterated, so when you prepare for crown in older people, there is less chance to open the pulp near the horn area, near the area of the pulp horns. And we can find cells and cell number. Of course, we have connective tissue cells, and we have immunological cells in the pulp, and the cell numbers will be reduced with aging, and the matrix collagen amount is increasing, and bad collagens is increased even more. And as I mentioned you, not just collagen, but other fibers are increasing as well. And so blood vessels, nerves, lymphatic elements are reducing. And in the periodontium, you will see changes. Of course, it is a degradation of the tissues, and the width of the periodontium is reducing. So, as you know, the normal width of the periodontium, the normal diameter is 0.2 millimeters, but 0.2, sometimes 0.3, but with aging it can be reduced 0.1 millimeter width to 0.1 millimeter width. And the gingival epithelium becomes thinner and less keratinized, and but this epithelium degradation or the thinner, becoming thinner, is general in the oral cavity. So it is affecting not only the gingiva but the oral epithelium as well. And you have the problem with the connective tissue, that the principal fibers of the periodontal ligament is less organized, but you will find more collagen fibers, but the problem is that it is less organized. And as I mentioned you, there are non-collagen fibers and bad or abnormal collagens which are increasing in percentage and in number. And PDL, in PDL again cellular content is reduced as well. And when you have bad oral hygiene, it means the plaque accumulation is increased because you cannot clean perfectly. The inflammation process and the degradation and loss of tissues, bony tissues, and attachment loss and bone resorption, you can see in the periodontium easily, because more easily than in older, in younger persons, because the resistance of the periodontium is decreased. And in the cementum, you can see less regular cement, and as you know, in older persons, the cell content cementum, so the cellular cementum is predominant, because after eruption and reaching the occlusal plane, the cellular cementum is forming. But sometimes you can see that even no cellular cementum is forming. And the cementum deposition will compensate, so it is an adaptation process, will compensate the loss of